I think the current staging systems or classifications that are used routinely in the clinic uh, either use simple biochemical measures of tumor burden, like beta 2 microglobulin and albumin. This is a commonly used staging system called the ISS and was recently revised to include or incorporate certain high risk cytogenetic features. So, my group has a paper coming out soon in Science Advances where we actually took a more holistic approach at classification by integrating the whole genome, whole exome, and RNA sequencing from over 650 myeloma patients that were profiled as part of the MMRS Compass study. And what we found was that the current staging systems could be further refined. To give you an example, in the ISS and even revised ISS, the 1Q copy number gain is not yet incorporated. And what we found in our classification system through PSN, which is a computational network modeling methodology, is that if we incorporate 1Q amplification into the current staging systems, it actually discriminates further within ISS 1, 2, 3 or revised ISS 1 to 3 patients that have particularly bad prognosis. So not all patients with good prognosis have the same end result. The patients can be further refined by looking at co-occurring genetic lesions, which is what we were able to do with this computational methodology. So this approach, I think, is increasingly being used by the myeloma community at large. And I am hopeful that the staging systems will be updated to reflect these multi-omics findings to refine the correct classification of patients.